Good evening. Today I'm with Dr. Rikhil Patel and Dr. Anthony DiMaio. Dr. Patel is a podiatrist. He went to Rutgers University in biomedical engineering. Then he went to Temple School of Podiatric Medicine, and then he got a additional residency in surgery at Phoenixville Hospital outside of Philadelphia. And with Dr. DiMaio has a bachelor's degree in exercise physiology and a minor in aquatic therapy, both of which I did in my outpatient therapy. And he's got a doctorate in physical therapy, all from West Virginia University. These gentlemen are going to talk about some ideas with podiatry, and Dr. Patel.
Mm-hmm. So yeah, thanks for having us, Bob. So we wanted to talk about just how people with strokes can rehab, specifically to actually get them walking again,
right? And
any other goals they have. So typically, when a patient comes to me, it's usually for other things, and then we catch this along with my exam, and right. I realize they have a functional deficit, and I asked them whenever they have a stroke or injury or any nerve type issues, how they got it and why they have it. And most of the time, I could honestly say no one's had rehab specifically for the foot drop.
Right.
They've had rehab to get back to live after a stroke or injury, but they all use the device or drag their feet. And so Dr. DiMaio and I have our eyes keen to that, so we pick up on it. So when the patient comes see me, first I have to identify the problem, much like they had to do during the stroke itself.
Right.
And then I kind of look at what assistive devices they're already using,
right.
And bigger problem if they're actually using it properly or at all. Because I know when I used to do prosthetics, you could design this fancy leg, but if it hurts when you put it on, people aren't going to wear it.
Right.
I mean, so I'm sure Dr. DiMaio knows that firsthand. Then I take a look at their functional deficit. I actually feel for your muscles. I feel for the strength. I look at the way you walk. And see what type of compensation they're doing for that, because that could throw everything off. People have calluses on the other foot because they're putting so much weight on it. So I got to deal with that. Sometimes you get ulcers too.
Do people come to you without assistive devices?
Yes, they do.
They must.
And then they trip and fall, and then that's where they get into problems.
Right.
And get more injuries. So this is we try to head it off at the pass, before it becomes a problem. All right. And then just to improve their overall quality of life, to send them in the right direction.
Right.
Because I know you mentioned in your book and your website, if you only knew what to do, you could have recovered a lot faster.
That's correct.
Probably even more functional too.
That's right.
The problem is people don't know. So the whole idea of this foundation, I think, it was a great opportunity to let people know.
Well,
all right.
That's true.
Yeah, and then as soon as I finish with my patient in there, then I send them to Dr. DiMaio to get the proper rehab they need.
Right.
But with that, I'll swing it over.
Yeah, so building off of what Dr. Patel said, luckily for me, working in a podiatric setting with him, he's already done a lot of the heavy lifting in terms of figuring out where the deficits are and discussing with the patient, these are the kind of options you have. And like he said, from my perspective, it's very rare that people get specific treatment for their foot drop, particularly after a CVA, because there's other deficits, there's a lot going on, and like you said, the person has a lot of issues that they're trying to attend to, and time is of the essence. So it's quicker and it's easier to just put an AFO on a person or give them an assistive device and say, this is a primary deficit. It's going to be very difficult to improve. Learn to function that way.
So what do you mean by primary deficit?
So with a neurological injury, most common obviously is CVA. A primary deficit is the physical area in your brain that has been damaged, or in your spinal cord that has been damaged, meaning everything downstream from that, so to speak, will specifically be impacted. Now they used to think, 30 years ago, that a primary deficit, okay, that is what it is, it's never going to improve. And learn to live with it. Now we know that not only is that untrue, But if you have a primary deficit, that you can actually remap the area of your cortex through specific training, which I'm going to talk about in a second, by changing the number and the organization of your synapses. A secondary deficit is something which is more common that we see with the foot drop, where the person has had an insult and they've had a weakness develop or a contracture develop, and the gait pattern that they have been using to compensate for these deficits has made the deficits actually worse. And they weren't aware that there was anything they could do to improve those deficits. And then that's when he will typically see the patient, see the deficit could potentially be improved, and send them to me. And then I'll work with that person to resolve those deficits as best we can.
Right.
Yeah, and a lot of times he finds deficits that I can't even identify because he spends a lot more time with it.
Right. Sure, a lot more time with them.
Right, and the most important thing for any neurological rehabilitation, particularly CVA, is the specific training, the specificity of what you're doing. And as we were discussing, the most important thing to people typically is their independence, and a big component of which is walking.
Sure.
So that's wonderful, but the only problem with that is once people can achieve kind of functional locomotion from point A to point B, a lot of times that is kind of the end point. They don't work on improving it beyond that. They don't, and then that's when we can see the problem with the balance or the gait difficulties. And some of that is based on the current reimbursement model of our healthcare system, which I'm sure you talk about at length. It doesn't really give gravity to the situation. It doesn't give us the time that we need to improve the things that we need to improve.
So when therapy, when reimbursed therapy comes to an end, what are some of the things that you can suggest to people to keep that therapy going? I mean, obviously they can pay,
right?
But then besides that,
even if the person was going to pay out of pocket, for the amount of training that you need to remap your cortex and to develop that motor learning, it's heavily dependent on the patient. The patient should know by that point. The therapist should make sure that we do a good job of educating them on what they need to work on. But a lot of the responsibility, unfortunately, falls on the patient, because whether you're with me only 1 hour a day or 2 hours a week, you're with yourself 24 hours a day. So the patient, you have to really educate them on what their options are and what they can work on. And the principles, the general principles of the rehabilitation, which are essentially, in layman's terms, use it or you lose it. Meaning, if you don't practice the dorsiflexion in this specific example, you will not get it back. It's not going to just improve.
And what's dorsiflexion?
So dorsiflexion is the motion of your toes coming up towards your knee, essentially, which is important for us usually when a person is swinging their leg through while the leg is in the swing phase, or lifting their foot up onto a step. That's common for people to catch their toe and then fall forward or lose their balance, something like that. And we also know that not only if you don't use it, you will lose that ability, but if you do use it, you will improve it. And we've seen that anecdotally. We've seen evidence of it. It's in the literature, everything. And the more specific the training to the activity you want to do, the more skilled and specific the training is, the more time you spend on the training, the more intense the training is, and the saliency, the importance of the training to the person, the better result you have. That's the most basic principles of neurologic rehabilitation.
And should people be practicing every day?
Every day.
Every day, right?
I tell all our people, the more you practice, the better. You're not going to over practice. You're making a motor pathway. It's like your golf swing. It's very difficult to over practice that, but if you grease that groove, so to speak, in that neurological pathway, you have a better chance of improving it. The more, just like anything else, any activity or sport, the more you practice it, the quicker your brain is going to adapt to that, and the better off you're going to be.
And falls are a big issue, because I've read that if you fall once, you're twice as likely to fall a second time, and then if you do it enough times, you're falling all the time. So that you want to avoid that, and so creating that functionality is really important. So any other suggestions, gentlemen?
Reach out early.
Time is of the essence.
Time is of the essence.
Yes, the earlier you get started, the better off you will be.
Okay, well, thank you, gentlemen.
Thank you, Bob.
Appreciate you coming.
Thank you.
Thank you.